My name is Scott Celinski. I'm a surgical oncologist and hepatobiliary surgeon at Baylor University Medical Center in Dallas. So what patients with pancreas adenocarcinoma are candidates for surgery, and what are our approaches and outcomes to this approach? Um, so generally, anybody who has a resectable pancreas cancer without metastatic disease is a candidate for surgery. And when I say resectable in this case, I'm referring more towards operable rather than the classification of potentially resectable, borderline resectable, or locally advanced. If their cancer is potentially resectable and the patient is medically fit, they are definitely candidates for resection. Generally, patients with metastatic disease are not resected, as outcomes historically have been very poor with very quick recurrences and lack of a survival benefit. But just as in other cancers like colorectal cancer, that is likely going to be a moving target. And as our systemic therapies get better, these patients probably will eventually be considered operative candidates also. When we look at pancreas cancer and think about resection, we generally break down cancers into their location, head cancers versus body and tail, which are completely different operations in order to get them out, with the head cancers requiring a Whipple operation, the tail and body cancers requiring a distal pancreatectomy. When we're looking at these, both of these locations, resectability generally comes down to vascular involvement. The pancreas is located in a very busy area anatomically, where the major vasculature to the abdominal organs from the celiac artery and the superior mesenteric artery is involved, as well as the venous return to the liver through the SMV and the portal vein. And so in this area, we tend to break them down into potentially resectable, borderline resectable, and locally advanced. Potentially resectable basically means that the major vasculature is not involved. Borderline resectable means that technically we can get it out with some involvement of the mesenteric vessels, but we have a much higher chance of having a margin positive resection. And then when we refer to locally advanced, they tend to have more significant involvement of the mesenteric vasculature and a significantly lower chance of resecting them with a negative margin. So treatment generally involves upfront resection for resectable cancers, though neoadjuvant therapy is starting to become more popular. And hopefully in the near future, we'll have a clinical trial to answer the question in resectable cancer, is neoadjuvant or adjuvant therapy the better approach, now that the standard therapy for both is FOLFIRINOX. For borderline resectable tumors, generally these are treated with neoadjuvant therapy. Approaches differ between institutions. Some favor chemotherapy, some favor chemoradiation, and others advocate for both. Our institutional preference is going to be chemotherapy first, as distant recurrence is generally the most common form of failure after surgery, and then we selectively use radiation. For locally advanced tumors, we tend to treat them with neoadjuvant therapy, many of which can be converted into resectable lesions with a response to therapy. So our outcomes for pancreas cancer have been improving rapidly over the past decade as surgery has become more routine and chemotherapy options have improved. Over the past decade, the overall survival for pancreas cancer in the United States has gone from about 4% for all comers up to 10%, which still is not anywhere near as high as we would like it to be, but is a significant improvement. When we look at outcomes for the surgically resected patients, those are also improving, and certainly in clinical trials are becoming very good compared to historical controls. The data for adjuvant FOLFIRINOX, even in the setting of a margin positive resection, has a median survival approaching 5.5 years, which is unheard of previously in pancreas cancer. Obviously, this is a highly selected group of patients who did well enough to make it through surgery and recover within 12 weeks to get onto chemotherapy, didn't have early recurrences, and didn't have significantly elevated postoperative CA19-9s in order to be included in the trial. But this does show that we can have excellent outcomes after resection of pancreas cancers.